Count down for me.
3, 2, 1.
Welcome everyone to our 8th breast lecture program this evening. If you missed the past lectures, you are welcome to contact us and we will send you the link for the past programs. They've been excellent. Dr. Zara will be updating us on the ever-evolving field of genetics tonight. Dr. Zara grew up in Lebanon and attended medical school at the Polytechnic University of Marche in Ancona, Italy. Yes, he does speak Italian and Arabic and French and Spanish and of course English. And I hear from the patients that he's very fluent. So impressive. He completed his internship and residency at Danbury Hospital, so he really knows Connecticut, and his fellowship in hematology and medical oncology at Brown University. He joined the Whittingham Cancer Center in 2004 and has served in multiple leadership roles throughout his career. Currently, Dr. Zahrah is the medical director of the Oncology Hematology program here at Norwalk Hospital. He's held an appointment at Memorial Sloan Kettering Cancer Center and continues to collaborate with the MSK team. Dr. Zahrah is involved in clinical research trials, along with being the director of genetics. I know he will provide us with the latest information in this exciting field of genetics. Thank you, Dr. Zahrah, for joining us and sharing your expertise this evening.
Thank you, Mary, for this very nice introduction. And thank you, Eva, in the background, making this happen as well. There's a whole team that folks don't see that have made this series doable. And I'm really proud to be part of the speaker program. So we're going to discuss some issues related to breast cancer genetics. We're going to discuss the current state and future directions. This may seem a bit too simplistic for some people on this talk, and it's going to be a little bit too complicated for some others. So I'm trying to balance things and see where it goes. Trying to get you intrigued, interested, hopefully, and maybe get some questions towards the end. I promise I won't really keep on talking for a long time and give a chance to people to ask questions. So moving on, I have no conflicts to disclose. So, you know, people when they kind of come to us with a diagnosis of breast cancer or having a family of breast cancer on their mind, there's a lot. Nobody can minimize this. And being a medical oncologist, we have to reassure them that you know, a diagnosis may be there, or they may be at risk of having a diagnosis of breast cancer. But out of other issues that we discuss, it's really on people's mind. It's a lot of the patients and the family members come in and say, this must be genetics. This must be because my mom had it, my grandmother had it, there's other cancers in the family. And I got to tell you, it's actually probably not the case. So we start off saying that the overwhelming majority of breast cancers are actually sporadic, meaning they happen and they don't happen because you inherited a gene mutation from your family, but they happen because of some known risk factors, and in a lot of situations because of the environment we live in or other risk factors, but not clearly genetics. And roughly about 5 or 6% of these cases are caused by a pathogenic variant. So you're going to be familiar with this terminology, I hope, before the end of the talk, and the BRCA1 and BRCA2 genes. So those are clearly the first genes and mutations that were found, and people built on this. Scientists, researchers kept on digging in. And as research became more and more available and technology became more available, And as we're now able to sequence the genome, one is easier, two is cheaper. We're able to find other genes that account for another small proportion of cancers. So these other pathogenic variants, they are in a high or moderate risk genes, and they account for another small percentage of breast cancers. And again, the terminology here is PALB2, TP53, P10, CHEK2, and ATM. May sound like an alphabet soup to you, but they're in a way either connected to BRCA1 and 2 in terms of functionality, or separate from that. It depends on where they are and how they act in the biology of cancers. So yes, certain individuals with a personal or family history of breast or ovarian, prostate, or pancreatic cancer may benefit from hereditary risk evaluation, but we got to be careful about what we offer to patients, and we got to really counsel them in terms of what to expect results and what are they going to do with those results. But how do we do this? It's getting a little bit more complex, especially if we look at the different societies that have not usually, recommendations that are in line with each other. So there's some discrepancies in what the NCCN guidelines, which oncologists consider almost like their Bible. These are guidelines that dictate, they give us recommendations about how to handle treatments of cancers, prevention recommendations, diagnostic issues to consider, workup, on and on. American College of Medical Genetics and Genomics have their own guidelines. The National Society of Genetic Counselors as well. The American Society of Breast Surgery, they came up with guidelines. At some point the past couple of years, it was considered to be very aggressive when you talk to a medical oncologist about what the surgeons are recommending. Now we seem to be embracing them and agreeing to most extent that any patient with a breast cancer diagnosis should at least be offered the option of genetic testing. Certainly counseling about what it entails, what to do with the results again, but at least offering the option, making it available, and the patient and their family could decide what's the right thing for them. The United States Preventive Service Task Force as well have their own guidelines. So not too long ago, and I came to Norwalk in 2004, we established a program not too long afterwards. And we used to have these cheat sheets where, you got to come up with what the current guidelines are, and these guidelines would change on a quarterly basis. And we need to stay on top of it and make sure we don't miss people. The key point is really to not to miss those few percentage of patients that could carry the mutation, because it could potentially have devastating consequences. You may be undertreating or not screening appropriately, or not counseling the family members, or not intervening with some recommendations about prevention. But so we, initially it used to be a breast cancer patient, a female breast cancer patient diagnosed at less than 45. Certainly when they're a bit older, 46 to 50, if they have a diagnosis, but they have a limited family history. And I take that and I jump a little bit back and forth. Limited family history and somebody who's either has no siblings, have been adopted, Ashkenazi Jew, where they lost family members, they don't have an adequate history to provide us. You can't assume that there is no history of cancer. You got to assume possibly the worst and try to include those patients and offer them testing. Multiple primary breast cancer, so it's either in one breast and another year another breast, or a second breast cancer, even if it's in the same breast. or more than one blood relative with these listed cancers that you see. So ongoing with the criteria, the older the woman, the more the burden of proving that they should be counseled or tested. So more history of particular cancers that would lead us in that direction. Over time, it became clear that ovarian cancer, even one case in the family, we should not be missing those, because with ovarian cancer, you're dealing with a difficult cancer to screen, to detect at an early stage, and most commonly women would present with advanced stage and a prognosis is terrible. So genetic testing became much more liberalized for those women and patients and their family. Same goes for pancreatic cancer, or what we call high-risk prostate cancer, so high grade and particular characteristics in those cancers that we look for. Triple negative breast cancer is known that if even there's one case in any patient at any age, that would be an indication for counseling and testing. Same applies to a male breast cancer. So yes, breast cancers happen in males. They're rare, but anytime there's a case in males, we would think of a possibility of having an underlying mutation. There are particular breast cancers that are called lobular, and when they're associated with either a personal or family history of a particular cancer called diffuse gastric cancer, then we may want to be thinking about a particular mutation called CDH1, and so that would be an indication for testing as well. Pancreatic cancer is already mentioned, high-risk metastatic prostate cancer. Ashkenazi Jewish ancestry plays a big role in making some accommodations or being a little bit more aggressive in picking those patients and family members for testing, to the point where even just being Ashkenazi Jew with a family history, so you yourself don't need to be affected by a cancer diagnosis. If you desire to pursue testing, it would not be an unreasonable thing to do. And other criteria that you see here, in addition, we use risk models to assess what kind of risk are people having to carry a pathogenic variant. And anytime that risk is more than 5%, that would trigger the potential for counseling and testing. Cascade testing is important because as we're thinking about the patient in front of us or the family member with us and we're counseling them, you got to think about what would happen to those patients' family members, and if the person in front of you it ends up with a pathogenic variant. So of course, you're going to counsel them about sharing that information with their family members, their loved ones, so that they can pursue counseling and testing as well. Well, additional particular groups in our practice that we see is now we do perform genetic sequencing on tumors. We call that genomic testing. So you're looking at the actual genetic profile of the tumor itself. And at times you may find that there is a somatic mutation. So it's a mutation that's found in a tumor, but a germline mutation is what is carried in the family and inherited. So if you see that there is a somatic mutation, a BRCA gene, or there is something called MMR deficiency that could suggest a particular syndrome called Lynch syndrome that would carry a risk of many, many cancers, depending on which particular mutation we identify, that would trigger. So by finding the somatic mutation, one should be looking at germline mutation and testing that patient as well. The TP53 is a more complex story there. It's a pretty rare mutation that would run in families. It's an important mutation not to miss. It would cause a Leigh-Fraumeni syndrome that would be carrying an extremely high risk of many different cancers, including breast cancer at a very young age, even in a 20 or sometimes younger. acute leukemias, among other cancers that could happen. But P53 is a very common somatic mutation found in tumors. So those would be, we see them a lot of times, but in absence of a family history, it would not really automatically trigger testing for that to find a germline mutation. It's actually more of the opposite. We got to be very selective in testing appropriate people only. Well, the concept of testing is more complex these days. On one hand, there's organizations, associations, the USPSTF recommendations actually tell us that we really better focus on testing as little as possible to get the same outcome without, compromise of outcomes, but try to limit your testing to the absolute necessary. The ASCO guidelines are sort of along the same line, but they tell us to be conscientious about costs and try to look into whether it would make sense when you're spending that dollar if you're going to get the yield that you're looking for. On the other hand, the philosophy of testing more, on one hand, the whole genome sequencing is cheaper these days. Now, cheaper is always relative, so I don't even dare ask people, what is $100 value these days, and whether you got to be very careful in discussing these issues with patients. But this is at a society level. The cost of whole genome sequencing dramatically came down. So does that mean that we should be using it more and more? MRI of the breast is more and more available. Cost went down as well, and it's able to save lives. I'll show you a slide about that. So now should we do it across the board for more and more women? And, if you're going to find some sort of mutation and you have some sort of risk, where do you draw the line? When do you start doing MRIs? And should you generalize it to everybody? Should we skip mammograms? The answer is quickly no. Mammograms are still much cheaper. They have their role in screening, and they're able to detect most of the cancers. But MRI certainly will play a role in some cases. And then there's the diagnostic yield philosophy. Is that sufficient to diagnose a cancer? So, we could be seeing breast cancer one after the other, and they're all diagnosed with a mammogram, but then you get to one that's missed. And is it 1 in 20 or 30? It doesn't matter. Is the fact that we found that one, are we willing now to say, well, MRIs across the board? So I don't have the answers to those, but we have data to support one thing versus another and guidelines to tell us which way to go. The current initial genetic testing method these days, when we used to initially do a BRCA1 or a BRCA2 gene and counsel people and do what we used to call reflex testing. So you could assess a risk in a family member, a patient, and then start with a BRCA1/2. And if you get a positivity, then you may want to stop. You may have gotten your answer. Or if you didn't get your answer, you're not satisfied, all right, let's move on to a bigger panel. This has gone actually by the wayside, and we don't favor this approach anymore. There's a lot of, there's good science behind it. It's logical, but on the practical side of it, our genetic counselors are getting overwhelmed. The volume of people you want to counsel, get testing, get results, manage the financial aspect, on and on and on. And then try to do more testing, and then how many steps is that going to be? Is the insurance going to cover a step of the way? So we really moved away from that. And at this point, we do a multi-gene panel testing, but even that is a multiple layer. So it could go from 5 or 6 or 7 genes to upward of 80 genes. And we have to be conscientious about what we're doing and fitting the right approach for the right patient, depending on their situation. So 4 to 7% have a pathogenic variant in other genes with what I call HBOC association. That's the hereditary breast and ovarian cancer syndrome. Those gene mutations, we call them moderate risk genes. And those include the CHEK2, PALB2, and ATM. So what does moderate risk gene? I'll explain to you in a second. But keeping on talking about BRCA1, BRCA2 seems like will be a basic at this point from the genetic perspective. Most people know about it. They know pretty much what kind of recommendations to go about it. It gets more complex when it comes down to these moderate risk genes. So test is performed, prior to the COVID pandemic, it used to be spit in a cup. We send it off. It's easy to do. We could deliver the cup home and we teach you how to do it and you send it to a company. These days, it's mostly a blood draw for obvious reasons. I found it hard to spit when I'm having the mask on. So not happening, but more limited testing may be appropriate, as I mentioned, and there are caveats to that. So you're going to get familiar with the term of VUS. It's what we spend most of our time talking about as with genetic counselors and dealing with genetics. That's called a variant of unknown significance. So the more you generalize testing on patients, populations, the more you may see a mutation, but it's a variant that was not seen before or seen but not sufficiently to be able to call it benign and forget about it, or pathogenic and deal with it. So we see a lot of those situations, and the more we test and the bigger the panel, the more of a chance that we're going to see this. In addition, more limited testing would be extremely appropriate in a family where a patient has a cancer, was found to have a pathogenic variant, and now we could test for that variant, and we don't need to bother in most situations with more extensive testing. Limitations of the multi-gene testing, I alluded to a few already, but mostly beyond that, individuals need to be prepared for what comes when you find a high penetrance variant. So we really counsel about, if you were to be found with this particular mutation, those are the things that we may need to discuss, and they are tough talks. But if you're not prepared for this, patients may be hit with, my God, now I have this, and what is that? I'm going to have cancer, I'm going to die, I'm going to be on chemo, and it's actually, most of those situations don't actually happen. So having a plan ahead of the testing is priceless. It empowers our women and their families to do the right thing and move in the right direction. Tough talks would be in particular mutations, and we have seen those, unfortunately, but at times you may see a mutation that you don't expect at all. So CDH1 I already spoke about. It's a combination risk of a particular breast cancer and a gastric cancer that's very hard to treat. So you want to prevent. So there's going to be discussion about having a prophylactic gastrectomy. So having the whole stomach taken out, and that could be a life-saving procedure. But if you face a patient who has this mutation but has no family history of gastric cancers, but how do you reconcile those two findings? That's something that is done by professionals, I gotta say, and it takes a lot of counseling. And you may be very well referred to physicians, to experts who just manage that. And we have actually done that on a couple of occasions. There is no talk in oncology and breast cancer in any symposium I've been to lately that there would not be a discussion about population health and access to health. So, most of the studies that have been done now, most of the publications that I may even tell you about today, the majority of the data will come from Western European white population, US population, and Hispanics, African Americans, Asians, they would be way underrepresented. So I speak about this because we deal with this on a daily basis. So we should be aware that the likelihood of finding a VUS is going to be higher in those populations. These are people who will not have the same access to the testing. Even as testing got cheaper, it's still pretty expensive. So we need to be sensitive to that. So on one hand, when we're ordering testing on everybody, we want to include people from different race and ethnic background, because that's how we're going to ultimately learn about these VUS and eliminate them or reclassify them. And this is how we're going to engage those people so that they have access, get tested, and get in those databases as we move forward. So one word, one slide, important about direct-to-consumer testing. One of the particular names that people may be familiar with is 23andMe, and it was approved in 2018. It's easy to access. It is cheap in a way, again. There's no pre or post counseling, and it's advertised that it will test for BRCA1 and 2. But the point is, it does include BRCA1 and 2 testing, but it's limited to the 3 Ashkenazi Jewish founder mutations. It does not completely analyze these genes. It does not identify all the mutations, and there are other potential variants that could be missed. And any individual who tests positive with these should undergo testing to confirm that result. Now, I got to tell you, the odds of having a false positive in anything we discuss here with genetics is extremely unlikely. But regardless, if there's a positive test, we still recommend having a clinical lab confirm that result. Now, one of the other points that's important to highlight is if women decide to get that test and then they get a negative, there's no BRCA mutation in the 23andMe, they may be falsely reassured that, okay, well, now I have a negative genetic test. I'm not going to run a risk of breast cancer. I'm done. I don't need a mammogram. I don't need to follow up with exams. And that could be very misleading. So some caveats about this. Availability of this is, I guess it's nice in certain situations. I'm not sure. I can speak to that. But you got to be careful about what you're looking at with the results. So this is where the importance of genetic counselors. I am lucky, we're all lucky to work with extremely hardworking, smart genetic counselors here. And they do a lot of this. And this is all included for the community to tap in. It's a resource that is, very few hospitals would have, and we do have right here. So they go through medical history, both personal and family. They get a detailed pedigree. They cover 3 generations. They provide estimates of cancer risk. Through risk models. They decide. They educate about the likelihood of testing positive, what options you have, potential benefits, limitations, risks of testing, address financial considerations and taking it forward. If testing is done, they would follow through with the companies, trying to minimize the burden, and they work with the whole team behind the scenes. Discuss legal protection against genetic discrimination. So in the US, we're very lucky. There's laws that lock in and protect you from discrimination. One particular situation that comes up repeatedly is life insurance. It's a sensitive subject, and patients need to be counseled about this separately because that's a commercial product, and sometimes it could be affected. So moving on to what we call moderate risk variants. As you see here, and this is a New England Journal table that shows you the BRCA mutations with their projected relative risk of breast cancer. For people who are not familiar with this, relative risk of 1 would tell you that a patient would have the average risk of the average population. And anytime you go higher than 1, then the risk is high. And anytime you get below 1, then the risk is lower than average. And you could see that the risk for a BRCA1 mutation is could be close to 90%. Same thing for BRCA2, but there is a different distribution in terms of age, with BRCA1 affecting younger women compared to BRCA2. But other cancers associated with these mutations would include ovarian and pancreatic, and the BRCA1, ovarian, prostate, and pancreatic, and the BRCA2. And on you go with the list of mutations. By far, BRCA1 and BRCA2 would be the most common. As you go in the less frequent mutations, you could still have different syndromes with different risks and different age distribution and the different cancers that you may encounter. The low to moderate penetrance, I'll be talking about again and again, so you could see these listed here with the particular syndromes. And now you're going to look at the relative risk that is way lower than what you see with the BRCA1 and BRCA2. Now, probability of breast cancer and ovarian cancer during a 10-year period, you're looking at the BRCA1 in the grayish color, and the other one is the BRCA2 age distribution. So trying to explain this by age and relative risk over the y-axis. And you could see here the particular risks for breast and for ovarian cancers. So this is another way of looking at the moderate risk, and actually I find it to be a little bit clearer by putting it in a graph. Again, if you look at the x-axis, this is the frequency of the different alleles or mutations that you may see. So the further you go, the more frequent that you're going to find these mutations. The relative risk is on this axis. And again, 1 is the starting point, and as you go higher, it gets to 10-fold the risk of the general population. And you're going to see the top BRCA1, BRCA2, the P53, that's the Li-Fraumeni, P10, CDH1, and STK11. But then in between the high risk and the low risk is the moderate risk mutations. And you could see around the 2 to 3-fold increase, or a little bit less than that actually, for CHEK2. So the 2021, so actually I'm having a hard time getting to the year, was a very important year. Actually, several studies have been published. This is coming out of the New England Journal of Medicine article with the Breast Cancer Association Consortium, looking at 60,000 breast cancer cases and comparing them to 53,000 controls. And you see the distribution of the gene mutations that you see, in addition with their particular variants and risk compared to the controls. And you could see here with the BRCA how much higher compared to as you go down in the low risk categories, how the risk goes low, and gets to the point where you may see that some of these mutations are actually either the same as control or even lower. And looking at this that I bracketed for you, it will include basically the PALB2, P53, CHEK2, P10, and ATM, looking at the moderate risk mutations, and then everything else would be much lower. But when you look at particular cancer, particular pathogenic variants, their particular risk being BRCA up here again, PALB2 almost in that, and then everything down lower. Now, if you look at these particular genes and you look at the particular disease, so breast cancer, if it's a ER positive versus ER negative, now you're going to see that the different genes have different frequencies. And triple negative breast cancers, you may start seeing more of the BORD1 RAD51C and RAD51D, compared to ATM and CHEK2, as well as BRCA1, BRCA2, and PALB2, and the ER positive ones. Now, we do include BRCA1 just so that we're not confused about this in the triple negatives, but we do see the moderate penetrance genes as listed down here as well. NCCN guidelines from 2021 with a nicely listed graph that looks very busy. But then, my point of this is, what are you going to do with this? Now, we ended up testing a patient, finding that they have a particular mutation, and what are we going to discuss? We're going to go over certainly screening. This is an unaffected patient, so if there's no diagnosis of cancer, but something led to the testing and they were found to have the mutation. So for every mutation, we have recommendation on what particular screening for breast cancer. Do you need to go beyond screening and discuss preventive mastectomy? And if so, at what age do you start? What do you combine in terms of testing? It's a lot, but honestly, right here, you could see that clearly for the BRCA mutation carriers and for PALB2, P10, and as well as, the moderate risk genes, you could certainly recommend an MRI. The younger age will go for the Li-Fraumeni as well as the BRCA1, and then you could start later on with the others. And the listed ages here, we could go down to 40 or even 50 and the NF1 gene mutation, for example. Discussion of mastectomy is totally appropriate. I would say it should be on a table anytime there is a mutation, but needs to be counseled very carefully, because when you get down to some gene mutation, the risk is pretty low compared to the other mutations, still higher than the average population. And then screening, more intense screening could be very appropriate, and avoiding drastic surgeries could be something that we would accept. So breast MRIs in a nutshell, don't be worried about how busy the slide is, but it's been studied repeatedly, but most studies have been focused on a BRCA1, 2, PALB2, and not including the moderate penetrant pathogenic variants. But extrapolation has been based on estimated risk levels. And I would say the studies have been consistently showing that you could, with screening, the probability of survival is upward of 90%. And that is just screening without actually, adding MRI to the mammogram, I'm sorry. So in this particular case, discussing beyond the screening tools, prophylactic mastectomies, and the BRCA1 pathogenic variant carriers, there's been a survival benefit that's been proven, 99.7 versus almost 93% for patients who do not undergo mastectomy, versus the BRCA2 carriers, where survival was not proven, even with a mastectomy. That could play because MRIs could detect those cancers at an early stage. You could still have curative surgery, possibly adjuvant therapies, depending on the case, and a mastectomy would not make a difference here. So these are observational studies. The recommendation is to add PALB2 to BRCA1 and BRCA2 with these recommendations, as the risk magnitude of more than 50% is there. Obviously, we don't have the data to comment on moderate penetrance genes, but if you don't see survival benefit with BRCA2, I would say it would be unlikely to show that benefit in the lower risk genes. So the USPSTF guidelines, in terms of, again, we started off speaking about screening, surgery, now medical therapies. And when we talk about medical therapies, we call this chemoprevention, but it's a misnomer. It's actually discussing hormonal therapy. in a preventative setting. Those are patients, again, that they do not have a diagnosis of breast cancer. And this is a unique opportunity. There's no similar scenario where you give a medication, you could prevent a diagnosis of cancer. But that applies to women with, again, risk models showing them that the risk is at least twice the risk of the average population. So the particular population we're looking at today with mutations has not been actually studied, but there's no reason to think that they would behave differently. Tamoxifen, raloxifene, and aromatase inhibitors are three drugs that could be offered in those scenarios with particular benefits, side effects, and toxicities depending on the drug. We always mention that there could be a risk of endometrial uterine cancer, as well as venous deep vein thrombosis or pulmonary embolism, depending if it's tamoxifen versus some risk of osteoporosis with aromatase inhibitors or worsening bone density. So in terms of medical intervention, I bring up this study not because it's studied in patients carrying a mutation, but because it was intriguing. This included patients with atypical hyperplasia, LCIS, or ductal carcinoma in situ, and patients were given tamoxifen 5 milligrams. So this is a low dose compared to the 20 milligrams, given for 3 years, extremely well tolerated. Follow-up at 5 years with 500 patients included in that study, it showed a significant drop in risk and no risk of cancers and clotting that we have seen with the standard dose. So I bring it up because more options become available, and certainly this is one thing that we could discuss with our patients who carry those mutations. In terms of treatment of patients, so we know that there's a class of drug now called PARP inhibitors, namely olaparib, that is talazoparib, and other drugs became more and more available. These were approved for treatment of breast cancer patients who have metastatic disease and whenever they have a BRCA mutation. So this particular study actually tried to include other mutations. We call this waterfall plot. And anytime you see these kind of going in the lower side of the graph, in this particular case, individual patients with PALB2 mutations, they showed that they carry the same benefit. And we could treat now patients with a PALB2 the same way we treated the BRCA population. Since the metastatic data in 2021, olaparib was approved as well as in the adjuvant setting. So people in the curative intent, after they may undergo chemotherapy and surgery, if they carry a BRCA mutation, they do benefit from olaparib as well. So genetic testing in those patients is, I would call it mandatory, because you would be missing out on essential treatments, and we need those treatments. We need to identify the patients that benefit from those treatments. The prognosis, a lot of patients come with a fear that just by carrying a mutation that they may have a worse prognosis. It's been proven to be not true. Patients with these mutations may have either the same or actually better survival. And there's some models projecting that their survival could get even better as we identify new targeted therapies because they carry a mutation. So most notable would be triple negative subtype. And, so that's more to come on it. Challenges on having these interpretations. This is one slide to explain how complex this has become, that there's the PROMPT study. Patients in the PROMPT study are basically patients that self-enroll. This is a registry trial, and these patients may be found with a variant of unknown significance, and they go on enrolling themselves, and part of the study, there's a prospective look at their outcomes. And actually, data starts trickling in, and there are some disturbing trends where physicians have inappropriately recommended prophylactic surgeries when a patient is carrying, again, a patient, I call a patient, but it's individuals with no diagnosis, carrying either a CHEK2 variant. We don't know if it carries an increased risk, and there's been at least a discussion or an intervention about prophylactic surgeries. So more to come on this as this particular registry starts giving us more data. On future directions and research priorities, there's many. I just decided to list a few. I think ultimately we need to validate personalized risk estimates for diverse populations. As I mentioned before, we need to optimize the screening and prevention by gene and not generalize everything just because we know this is what happens with BRCA and it needs to be generalized to everybody. Gene-specific data on risk-reducing medication. So again, low-dose tamoxifen, I gave the example. Is this something that should be discussed? If so, with who? So more to come on this, and research obviously will hopefully shed the light on that. Clinical trials of targeted therapies, PARP inhibitors, as I mentioned before. Immunotherapy has become an extremely important intervention specifically for triple-negative breast cancer patients. And then education and risk communication for patients and clinicians to avoid those scenarios that we just described. Well, I cannot conclude this without just advising everybody in case they don't know, again, about what we have available here. Full cancer genetic services, 2 genetic counselors in Norwalk, 2 more in at Danbury Hospital, and more at Vassar Brothers. So navigators are available to help you. You don't know where to go, you don't know what to do. Mary's there. I'll give you her cell phone, just you gotta hang in for a little bit more. I'm glad she's on mute, otherwise she's gonna tell me something there. Referral to medical surgical team. So you get the result, you don't need to panic. You know, you'll be referred to the appropriate people, experts in whether it's going to be medical intervention, whether it's going to be the screening, whether it's going to be surgical intervention, or whether it's going to be the psychosocial support staff. I mean, there's a lot to be said about this, family counseling. It's all here. It's all here. It's available. And all you need to do is call the Smile Breast Centers, 203-852-4300. And with that, I thank you.
Great information, Dr. Zahrah. Wow, a lot to process. And boy, a lot has changed in the last 10, 15 years. That's really, I think, to me, the takeaway point. When I first came, I think we were just talking about BRCA1 and 2 genes, and now it's, you know, the genetic meetings are at least an hour long, full of cases and lots of discussion.
Yes, for sure.
What do you think is the most challenging? I guess it's kind of a double question. What do you think is the most challenging question for patients to be asking and trying to process when they hear that there's maybe a genetic mutation?
It's actually a really good question, which I never say that, a good question, but that's one that, because you brought up the one thing I almost uniformly, and people who know me may have heard this repeatedly. People come in with a fear of what they're going to find. And what I always start with is 9 out of 10 people that I see will test negative, and you're going to get back to your family and have the peace of mind. You know, so negative testing in the right setting, it will give you the peace of mind, especially if you came already with somebody in the family with that mutation, and then we target that and we test you for it and you don't have it. That's a true negative, we call it. So that's, you know, will eliminate the fear. Now, I caution everybody that you're going to continue with what you need to do. Screening appropriate for age. You're going to follow up with your physicians. You're going to follow recommendations. You're going to take care of yourself. You're going to drink less. You're going to eat less. You're going to exercise, do the healthy stuff. That's where the money is. I mean, we spend so much money about, all of the expensive tests, but we got to take care of ourselves. That's where it starts. So which part? I think the fear of what is this test going to get you? We want to eliminate that, because in most, overwhelmingly, I'll tell you, so yes, a negative test will give you peace of mind. Two, this is not about a good or bad news. This is about information that you could decide what to do with it, and you're not going to be blindsided and get a diagnosis and you think like, where did I get this from? You could actually plan how you're going to deal with it, live with it, and we're going to be there to support you.
Completely agree. I think it's just all about getting information and then planning ahead and helping your family to be informed. It's so important. Eva, do you have any questions coming from the audience? Unfortunately, we're not able to see those, and I don't want to keep asking Dr. Zahrah questions because perhaps there's some other questions coming in. So I'll keep asking my questions. Dr. Zahrah, what do you say to people when they say, oh, well, my mom doesn't carry the gene?
Sure. So you're alluding to, maybe, if I understand correctly, that we don't take into consideration that side, right? So obviously it's back to basics. You inherit your genes half from your mom and half your dad. You actually never had a choice. So this is not your fault by any means. And we have to take the history on both sides.
Yes, it does. We've got to remember that. I think another interesting discussion always comes up when you hear that information, you get that information. How important is it to share? Is it to share with your family members?
Yeah, that's a very sensitive subject, and knowing that we see some family dynamics, our responsibility is towards the individual in front of us, right? So somebody comes to us and we have to focus on what's best for them. We try to counsel as much as possible. Sharing information is obviously valuable on both ends, whether positive or negative. So we advise. The key for us is to educate and tell them what the consequences are of both sharing and not sharing. But then obviously we respect ultimately the individual's decision.
Right, right.
So we've seen extremes where somebody walks out and the genetic counselors would have the stories for you. Somebody walks out and they put it on Instagram or Facebook and people to see. And, I mean, it's what it is. or they're holding to this and it's theirs. So it's individualized, I would say.
Yes. Eva, do you have a couple of questions? I hear there's some questions in the chat, but we are not able to see them. The other interesting and I guess significant point to make here is that how fortunate we are to have two genetic counselors here at Norwalk Hospital. You want to expand on that with what happens across the country and how lucky we are?
We compare notes always when we go to national meetings. I know you know that, Mary, and then we look at each other and we say, like, how lucky are we? It goes, I think it's a little bit more than luck. I mean, we could not be doing this if we didn't have the right environment. So we are collegial. We mentioned the genetic counselors. I mentioned that you may need to ultimately get to the radiology place or go to a surgeon. I mean, every step of the way, you have a team that works very well together. We're here to do the right thing for the patient. It's not about, we want to eliminate barriers. We want to have people have access to their health, to their care, to their testing. So patients more and more know that we're not as rigid as we in some parts where, oh, you got to do this full hour of counseling and then talk to me after that, and then we're going to do this and we'll get back to you. We're here trying to adapt to the environment and make things happen. You could go to the surgeon and you get the stuff done. The surgeon would call me saying, you couldn't do this. They're coming to see you. We'd rather. Genetic counselors, they will sit in any office. They just unbelievable. They're available and they make things happen. So all of that goes to the full team.
Yes. And I just want to correct the phone number for Smilo. It's 203-852-2300. 852-2300. And I'm sure you'll get.
Did I get that wrong? Did I fail that one after? Okay.
I know you know the number. I think you just hit the wrong.
I just remember your cell phone. That's all.
Ava, do you have something for us? I think you're really trying to get in here, but we can't hear you.
Yes, I apologize. I didn't realize you couldn't hear me. So I have a question that came in. It says, how long should we wait to be retested if our first genetic testing was 3 years ago and mutations were not found then?
Yeah, so that depends on the actual test. So this is not about a COVID booster and you need to wait a few months and get it done. It's actually more about, so back in say 2011 and before, we may not have had the mutations that we have now, and an individual may not have had a full panel test, so limited to maybe BRCA 1 and 2. But if it's been a recent test within 3 years, it really depends on what kind of test was done. So if it's a panel test, I would say that probably it included everything, and there's very little that you could add. There's a lot of discussion about whether actually we get any meaningful information by keeping on retesting people. So that's a topic of a different meeting talk, and it gets a little bit more complicated. But anytime, if somebody had the test in 2018 and you have a question about whether you need to be retested, it would be best to discuss it with your physician, oncologist, surgeon, and get that answered.
So one other question to follow up to that is, if you get a VUS, the variant of uncertain significance, who tells you when it becomes reclassified?
Yeah, your genetic counselor, yes. So that we're keeping a tab. So depending on which company has tested, those companies keep a log of what's going on, and they update this continuously, and they give us a feedback, and we get back to the patient.
Very thorough. Great team. All right, I think we're at the end of our hour. I want to thank everybody for joining us. And if you've got any questions, please give us a call at the Breast Center, 852-2300. Email us, you know how to get a hold of us. We're all here to help in any way. Dr. Zahrah, thank you so much for tackling this challenging topic. I know that this has become second nature to you, but for many of us, it's complicated, and I think you've taken some of the sting out of it and made it a little bit easier to understand. Thank you. Good night, everyone.
Night.